Hello, my name is Belle. I currently work as a physician associate in gastroenterology. In this presentation, we will be covering two cholestatic conditions, primary biliary cirrhosis and primary sclerosing cholangitis. This information is geared towards students about to sit their examinations. For more information on topics, don't hesitate to email me. These are some of the outlines we're going to cover in this presentation. As mentioned before, there are a couple of cholestatic conditions, with these two being included in that list. These chronic cholestatic conditions each have distinguishing features and variable progression. Let's dive in. In the case of primary biliary cirrhosis and primary sclerosing cholangitis, unfortunately, the aetiology remains unknown. Individuals are thought to have a genetic predisposition of which, if they do come across said unknown factor, gives rise to either of these conditions. This is unfortunate as it means really anybody can be affected. Primary biliary cirrhosis. This is in reference to a cholestatic condition in which there is damage to the intrahepatic bile ducts. As mentioned before, there is no known etiological factor. It is an autoimmune condition. The theory, therefore, is that there is T lymphocyte-mediated destruction of the intrahepatic bile ducts. Interestingly, women are more likely to develop this condition. A retrospective analysis showed that PBC patients who were symptomatic at disease onset were often female and in the age range of 45 to 65. They were found to have greater derangement of the laboratory liver function test in comparison to the asymptomatic group. This is despite similar autoantibody profiles and histologic disease stage. Diagnosis of primary biliary cirrhosis. The first thing you want to do is take a full history. Patients may have noted worsening jaundice and lethargy. Interestingly, in some cases, the patient can be asymptomatic and actually not have any symptoms pointing towards PBC. I suppose you can say that these are the fortunate cases. The reason I make this statement is because the earlier the diagnosis is made, the earlier the treatment options can be discussed with the patient. The next thing you want to do is bloods. You will note that patients will have deranged liver function test results. This will be reflective of the degree at which the disease has progressed. ALP, for instance, in patients with PBC can be as high as 1.5 times the upper limit of normal, with the normal limit in healthy adults being 20 to 140. You also want to do an immunology screen. The presence of serum antimitochondrial antibodies. In the case of primary biliary cirrhosis, AMA will be elevated in 95% of cases. Most patients have an elevated serum IgM, but this is neither specific nor sensitive for PBC. It is mostly the antimitochondrial antibodies that we are looking at in this case. A key point to mention, some patients can indeed be AMA negative. There are some cases in which patients are positive for anti-smooth muscle antibodies instead, and still show features of PBC despite being AMA negative. Now, when it comes to imaging, we want to do MRCP. MRCP stands for magnetic resonance cholangiopancreatography. This form of imaging is used to determine if the patient has intrahepatic or extrahepatic biliary destruction, or both. This is especially important in patients that are AMA negative. And finally, we want to do a liver biopsy. Liver histology can help to support the presence of intralobular bile duct destruction. To confidently make a diagnosis, the investigations mentioned above are essential. Disease progression in primary biliary cirrhosis. There is variation in the rate at which this condition progresses. If you recall earlier, I mentioned that there are great benefits to early diagnosis, as there is a faster initiation of treatment and hopefully a better prognosis for the patient. Now, without effective therapy, the disease appears to advance a lot quicker. The median time to developing extensive fibrosis is approximately 2 years from the time the diagnosis was made. So I'm just reinforcing the point here that early diagnosis means potentially a better outcome for our patient. Treatment of primary biliary cirrhosis. Ursodeoxycholic acid is a primary pharmacotherapy used in PBC. It demonstrates the following properties in the management of PBC, with the mechanism of action as follows. It has anticholestatic, antifibrotic effects, as well as having the ability to neutralize toxins. We need compliance with this medication. Patient education should be part of management for any condition, really. If there is a poor response to the ursodeoxycholic acid, bile acid sequestrants have been used in addition to the ursodeoxycholic acid. Now, in the case of resistant PBC, we aim to do the following. 1. We can increase the dose of the ursodeoxycholic acid until we have reached an optimum response from the patient. Secondly, we can use benzafibrates. These are next line for the treatment of PBC. These are lipid-lowering agents. They have anti-inflammatory effects, antifibrotic, and anticholestatic effects. The mechanism of action in the management of PBC remains unknown, but this is what we believe is occurring and helps. It has been shown that when used in combination with the ursodeoxycholic acid, there is greater success in patient response. To patients not responding to the addition of the benzafibrates, the next line is obeticholic acid. The mechanism of action is that it binds to the farnesoid receptors on the enterocytes and hepatocytes. This receptor helps to regulate the liver's metabolism of bile and cholesterol. By binding to these receptors, this will increase the bile flow, therefore suppressing its production. This will therefore lead to a decrease in the levels of bile. The overall aim is to reduce bile stasis, thus inhibiting inflammation and cirrhosis of the liver. A retrospective analysis showed patients symptomatic on diagnosis were less likely to respond to ursodeoxycholic acid and progress more frequently and more rapidly to cirrhosis and its associated complications. Those complications being ascites, esophageovaricose hemorrhage, hepatocellular carcinoma, or death due to liver failure. This therefore highlights the point I made earlier. Early diagnosis, early treatment initiation, better patient outcome. Primary sclerosing cholangitis, PSC, is an autoimmune condition in which there is destruction of both the intrahepatic and extrahepatic biliary ducts. The aetiology too remains unknown, but the same principle applies as regards to the genetic predisposition. Interestingly, this condition mainly affects males, with the average age of diagnosis being around the ages of 20 to 40 years old. Another key point to remember is that individuals who have PSC are at a higher risk of developing ulcerative colitis in comparison to the general population, that is. The correlation is so significant that we have a policy in which we aim to have every patient with PSC screened for ulcerative colitis. The association is in approximately 80% of cases, and by that I mean 80% of patients with PSC will go on to have ulcerative colitis. But having ulcerative colitis doesn't necessarily mean that you will have PSC. Unfortunately, with PSC patients and ulcerative colitis patients, they are at a greater risk of developing colon cancer. These patients will need to be screened regularly due to this higher risk. Diagnosis. As we mentioned earlier, the same rules do apply. A disruption between structure and function will lead to the clinical manifestations seen in this condition. You want to take a good history. Secondly, we want to do the bloods. With the bloods, we can look at the liver function test. We're looking for patterns indicating derangement of the liver function. Importantly, in this condition, we must also do an autoimmune screen. Unlike PBC, in PSC, P anchor is found in approximately 82% of cases. In cases of PSC, patients can also have anti-smooth muscle antibodies and raised IgM. If IgM is present and raised, this may indicate that an acute case is taking place. MRCP. Now, MRCP is a very useful tool for visualization, as it can help us to determine if the destruction is both intra and extrahepatic. It can help us to differentiate between the two conditions. And finally, a liver biopsy. Histological examination is also a useful tool in the process of differentiation. Management of primary sclerosing cholangitis, ERCP. This stands for endoscopic retrograde cholangiopancreatography. This procedure will allow us to carry out stricture dilation, providing the patient with some symptom relief by enabling the flow of bile. Pharmacological methods. Unfortunately, in the case of PSC, pharmacological methods haven't been found to be as successful as they have been in PBC. Ursodeoxycholic acid is prescribed to such patients for the reasons that I'd mentioned before. Other pharmacological therapies that have shown a level of success are steroids and azathioprine, due to their immunosuppressive effects. Unfortunately, our options are to manage such patients symptomatically. Due to disease progression, the other treatment options available for such patients are liver transplantation. Any patient diagnosed with PSC will be referred to the liver transplant team for further evaluation as to suitability. Unfortunately, due to the damage the liver is undergoing, such patients are at a high risk of developing cholangiocarcinoma. My take-home message is, have a higher index of suspicion for this condition. The reason I say this is, the faster the diagnosis, the faster we can optimize management. Consequently, the better the outcome for the patient. Here is a summary of everything we discussed. Make sure you take a screenshot, write it down somewhere. Good luck in your examinations. Any questions that you do have, make sure to send me an email, which is in the description. And please subscribe to this channel for more content like this. All right? Good luck in your exams and take care. Goodbye.